Welcome everyone to the Canadian Nurses Association's webinar series, Progress in Practice. This webinar is entitled Supervised Consumption Sites, Where Are We Now? This session is being recorded for nurses who are unable to participate today. My name is Carrie Schuhendler. I am a registered nurse and policy advisor at the Canadian Nurses Association, and I will be hosting this webinar. At the end of the presentation, we will answer your questions, which you can type in the Q&A box that you see to the right of your slide. We will address as many questions as time allows. After the webinar, we will email you a link to the recording and a short evaluation. Once you've submitted your feedback, you'll be redirected to the Certificate of Participation. And now a little about our presenter, Marilou Gagnon. Marilou Gagnon is an associate professor in nursing at the University of Ottawa, a former board member and expert advisor in research, policy, and advocacy for the Canadian Association of Nurses in AIDS Care. She now serves as the board chair of the Canadian HIV/AIDS Legal Network. She is also founder of the Coalition of Nurses and Nursing Students for Supervised Injection Services, creator of the Facebook campaign Harm Reduction Equals Nursing Care, and editor of the Radical Nurse blog. This webinar is the third in a series about substance use trends in Canada. And now I'll hand it over to Marilou.
Thank you. Thanks everyone for coming today. There's a lot to cover, so I'll give you an idea of the outline of the presentation. I'll do a bit of a background that is important, I think, before we dive into the supervised consumption site in Canada, and then where are we now. And so I will do that, and then we will look at supervised consumption sites in Canada, where are we now in terms of research, policy, and practice, and where to go next. And so I just did this in French, and it was pretty tight, so I'll try not to talk too fast, but this is usually how fast I talk. If ever it's too fast, you can also type in, and I'll try to slow down. But it's definitely a topic that there's a great deal to cover. In terms of background, I never know who I talk to, especially in the context of this webinar, so I'm just going to assume that you don't know anything about harm reduction, and if that's the case, I'll just give you a brief idea of what the basic principle behind harm reduction is. So harm reduction recognizes that some things that we do in life may pose harms and pose a risk to our health. This can include having sex and playing sports and driving a car and, biking and drinking alcohol. And all these things can potentially pose a risk to our health. And these things also include taking drugs. So we have two approaches. The first approach is an abstinence-based approach where we tell people to stop doing these things. And we know that the abstinence-based approach, regardless of it's applied to sex or sports or car or alcohol or drugs, it does not work. Harm reduction actually takes a different approach. It looks at these things as thinking in terms of how can we allow people to keep doing these things, but then reduce the harms, and don't necessarily expect them to stop doing these things, but actually look at how, as healthcare providers, we can decrease the harms by different programs and policies and approaches. So in the context of drug use, harm reduction tends to refer to policies, programs, and practices that aim primarily at reducing the adverse health, social, and economic consequences of using drugs without necessarily reducing or stopping drug consumption. So the goal with harm reduction is not necessarily to ask people to stop using drugs or to actually ask them to decrease their use, but it's regardless of what they do in terms of decreasing or stopping or continuing, what we want is to actually work with them to decrease the adverse health, social, and economic consequences of using drugs. So harm reduction is historically grassroots and community focused. It really started as a grassroots movement, not necessarily by healthcare provider, but mostly by people who use drugs and people in the community. It has been described as a pragmatic and patient-centered approach. It is an ethical and non-judgmental approach. It is also an evidence-based approach, and it's been proven to work in Canada, but also across the world. It is cost-efficient. It is also cost-saving. It is life-saving, and it is also a human right. So in terms of harm reduction in the context of drug use, examples would include safer injection education, so actually educating people on how to safely inject. That include the techniques you should be using, where to inject, which veins to avoid, what supplies to use, things like that. So that's harm reduction in the context of drug use. If you look at other examples like providing people with supplies so that they don't have to reuse the same needle or share a needle or share supplies, that's also harm reduction. If you think at programs, we don't do that that much in Canada, but across the globe, there's countries where you can actually test your drugs that you're about to take. It's particularly popular on the music scene and music festivals where people can actually go test their drug that they're about to take to know what they're actually about to take, and then make a decision of, is this what I wanted to take? Is this what I wanted to buy, or maybe not? So that's also harm reduction. Naloxone training, educating people on how to recognize an overdose and what to do and how to administer naloxone is also harm reduction. And of course, supervised consumption site is also a harm reduction approach. It includes many things. It's more than the supervised consumption part. It includes education. It includes supplies, prevention, and the biggest prevention piece about supervised consumption site is the fact that people are not forced to use alone, and we know using alone is the biggest risk factor to overdosing, and so by allowing people to come into that space and using not by themselves, then we already decrease by a great deal their likelihood of overdosing, and then having someone around to intervene if that happens. And there's also care provided and then rapid intervention in acute situations, which unfortunately tend to happen a lot. So the driving forces behind supervised consumption site historically has been three things: community mobilization, civil disobedience, and legal battles. Community mobilization it's true in Canada, it's true everywhere in the world where these services and these sites have really come about with people pushing at all levels for access to harm reduction for people who use drugs. So it's been at the level of people who use drugs, community-based organizations and healthcare providers and organizations, politicians, business owners, community leaders, and activists. So it does not happen just on its own, like it needs a great deal of push. There's also, a driving force has been civil disobedience. And if I use the example of Fixerum in Denmark, where actually nurses and physicians just decided to, get together and put together a mobile supervised injection service in a van that you see in the picture, and that's the quote, that's the way they explain it. They just had to put it to the test, so they were willing to be arrested, just to really push forward and actually force policymakers to make major changes at the level of harm reduction of the country, and it worked. And it's true in Canada too that the legal battles were also very important. And if you think of the Inside case, which is Attorney General versus Portland Hotel Society Community Service, this is one of the major legal battle that made supervised injection services possible in Canada. So I think it's important to understand the history in order to understand where we're at today. So what's a supervised consumption site? I divided it into three parts. There's a supervised portion, there's a consumption portion, and there's a site portion. So the supervised portion is that someone is present. But it doesn't have to be a nurse. And I think that's important to understand that the model in Canada so far, because there's only two sites, as we'll see later, it's been a model where a nurse is doing the supervised portion. But that's not true for every supervised consumption site elsewhere. So there's also models where it's actually a peer who's doing the supervised portion. There's also models where it's a harm reduction worker. So that's all up for discussion when you're talking about, okay, we want to implement a supervised consumption service or a site, so who's going to be the best person positioned to actually do this part? The consumption part is that the person can consume a drug without fear of arrest within that space, that service. So that person has to bring their own illegal drug that they're purchased on the street. And I put a little asterisk there just to say that ideally, if we're really serious about harm reduction, we should also move towards being able to allow people to inject and consume their drugs that have been prescribed by a physician instead of illegally purchased on the street where we don't know the composition of that substance, we don't know what's in there. And as long as that substance that the person is consuming is not regulated and safe, it's really hard to actually achieve safer injection, knowing that you can give someone a space and supplies and education, but as long as they're injecting a substance that's unregulated and unsafe, the likelihood of the harms happening are still pretty high. The consumption part is important to understand that we've been talking about supervised injection sites a lot, but some other models actually include the inhalation part, so people can smoke in a supervised consumption site. In Canada, that's not the case, and that's not really in the works right now. But in other models, sometimes it's also a supervised consumption site that includes both injection and smoking. We often talk about sites, but I like to also remind people that these can be services included in existing organizations and facilities. So if you take the example of Insight being built for that specific purpose of allowing people to inject at that site, and it's meeting that specific objective, it's one model, but it's not the only model. And it's often, like people say, if we use Insight as an example, it's tricky because it can't be replicated so easily. It's expensive. It's a big, long road to get there. But if you're thinking about a supervised consumption service, that can be easily integrated into a hospital, into an organization, into a community-based organization, into an existing facility. It doesn't require as much work and as much resource, but it has the same impact. It's just on a different scale. You can also think of a supervised consumption site as a mobile unit, and that's fixed drum is a good example of that. And the idea is not to just have that service or that site, but to provide linkage to care services and programs. So when were the first supervised consumption sites open? It was in the 80s and early 90s, mainly in Germany, Netherlands, and Switzerland. How many to date? I mean, I've been referring, and I'll be referring to this systematic review quite a bit throughout the presentation. It mentions 90 sites. That's pretty much where we're at right now. They're located in Australia, Norway, Germany, Denmark, Switzerland, Spain, Netherlands, Luxembourg, and Canada. So that gives you an idea. So in Canada right now we have 2 active sites as we speak today. So the first is Insight. Insight opened in 2003. It's in Vancouver. It was the first supervised injection site in North America, and it has about 600 visits per day, and that's still true today. The other active site that is currently under an exemption at the federal level that is operating actively is at the Dr. Peters Center, and the Dr. Peters Center is a good example of a supervised consumption service being integrated into an existing healthcare facility. So it was the first healthcare facility in North America to integrate a supervised injection service in its model of care in 2002. It opened in 97. It's a center for people living with HIV. So you have people there that go to a day center, but some people live there actually for a period of time. So then if they want to inject, they can actually go inject into that room that you see to your right. And then do that under the supervision of a nurse. And if something happens, the nurse is actually right next door. So these are the 2 active sites right now. The upcoming sites are 3 sites in Montreal. Cactus, Dopamine, and Spec de Rue are 3 existing community-based organizations that provide harm reduction services to people who use drugs. And what will happen within the next few weeks, 2 months, maybe, is that a nurse will be integrated into these existing organizations to ensure the supervised injection service portion that will now be provided in these 3 places. Sites that are waiting approval as we speak right now are in Vancouver, Victoria, Surrey, Toronto, Ottawa, and Montreal is still awaiting an exemption for a mobile unit that was put in as an application along with the 3 other sites, but did not get an exemption from what I know. Why is there a need for supervised consumption site in Canada? I would say, well, you have to look at the substances that people use. Alcohol and cannabis are still the most used substances in Canada, and they don't require a supervised consumption site. They require harm reduction approaches, and we can do that at different levels. But for people who inject or for people who smoke, they require these services. And it's really hard to get a sense of how many people inject drugs in Canada. One reference I found said 100,000. I know that in the downtown east side in Vancouver, usually what I see as a number is 5,000. And just based on the crisis that we've seen unfolding in Vancouver over the past year or so, a bit longer than a year. Last year alone, 914 people died of an overdose in Vancouver. So that's about, 1,000 of the 5,000 of people who inject drugs in Vancouver have died of an overdose last year, despite the fact that Vancouver has the most comprehensive and extensive harm reduction service provision in the country. And they have 2 active supervised injection sites. So just think about that for a second in terms of the needs and how, supervised consumption sites are part of a solution, but they're definitely some bigger issues, but they're definitely part of the solutions. They're needed also because we need to address the harms, especially of injecting drugs, and that includes bloodborne infections, skin and soft tissue infections, sepsis, endocarditis, pulmonary embolism, anaphylactic shock, overdose, and of course death, which is what we're trying to prevent, with supervised consumption services. Again, why is there a need? Because supervised consumption services also increase access to care for people often who are the most marginalized, disconnected from care, and also really impacted by repeated negative experiences with healthcare providers, with the system in general, with the welfare system, just disconnected from care, lack of trust towards healthcare providers with good reasons. And so it is a way of reconnecting with people who need care, who have complex health issues. And so it's more than the supervised consumption part. And if you look at it that way, I find it very narrow and not very helpful. But I think the most helpful approach to the conversation around supervised consumption services is to look at it as a healthcare service that goes beyond the supervised consumption part. There is, I've mentioned it before, an overdose crisis at the moment. It has impacted Vancouver and BC a lot, but it is impacting every province, and it is moving fast, and it's quite scary to see this unraveling. There's been a 327% increase in overdoses in Canada since 2008. I've put statistics there. I don't necessarily want to go over them because you can see them. But just to give you a sense that in BC right now, there's 4 people dying every day of an overdose despite the resources that they have, which is not comparable to any other province in the country. Ontario, it's about 2. We don't have any national registry or obligation to report overdose data in this country. There's no way to get a sense of the extent of this crisis. But from the ground, we know that this is actually really bad, and that supervised consumption sites are part of the solution. They're not the ultimate solution, but it's part of the solution, and it's one way to actually prevent overdose, among other things. And as part of the response in BC, we've seen overdose prevention sites pop up in alleys, and that's been a direct response of people needing more options than Insight and the Dr. Peter Center. And so far there's been about 20 overdose prevention sites open in BC, and that's what I've heard the latest numbers in terms of these sites. And what they do is basically they're operated by volunteers and peers. They basically provide that supervised portion that I mentioned before, and they intervene if ever someone presents signs of an overdose, and then they call 911 and save people's lives, basically. And they've been doing that in large volume, in part because people use these sites a lot because they get to do things that they can't do at Insight. For example, they get to split and share their drugs. They get to help each other inject, which they can't do at Insight. They get to smoke, which they can't do at Insight. So there's a lot of things that people can do at Insight, which is a corner, like not even a block away. It's right on the corner of one of these sites, and people go to these sites because they can go in and out. They don't have to wait. They can smoke. They can help each other. They can split their drugs, and they just go on to their business. And if something bad happens, then they can have the help that they need. So they've been very popular and very effective at preventing overdose-related death. So the research, what I've tried to do is basically capture everything you should know about the research that's been done so far, and just kind of a few slides. So just to give you a sense of what we know from the science. So in terms of the sources, I'm going to be sliding mostly from a systematic review that was done on supervised injection services, as well as a literature review on the effectiveness of supervised injection services that was done by the Ontario HIV Treatment Network, and other articles that I've just listed there. What's interesting about the systematic review is that 68% of the articles from that systematic review came from Vancouver. So Canada is a big producer of empirical evidence on supervised injection site. So we definitely have the expertise. We have the research here, and we know that it works, and there's a great deal of evidence coming out of Vancouver, enough to actually support the implementation of supervised injection services or consumption services across the country. So definitely well-renowned for being big producers of scientific research on this, which is really helpful because I'm sure, I don't know in terms of your level of and how close you've been following this in the media and at the level of policy, but I mean, there's always a ton of barriers against us when we're trying to advocate for supervised injection services. So having that science is really, really, really important because there are great barriers that we face as we push for this. So in terms of the research, we know that the characteristics of the users, it's usually male between 30-35, usually people who are housing insecure or homeless, with a history of incarceration, with a history of sex work, using mostly these 4 substances, which shouldn't be a surprise to you. The one thing I would say about heroin, though, is that right now people who think that they're buying heroin are not getting heroin. The people who are buying cocaine in Canada right now, they think they're getting cocaine. They're getting cocaine often laced with fentanyl. People that are buying opiates are thinking they're buying, the pills that they're used to take and crush and inject, but in fact they're injecting fentanyl. And so a lot of these substances right now are people are overdosing on them thinking that they're buying something when this is not what they're buying. So it's just the reality of an unregulated market where substances are produced and, underground market with chemists who are, constantly trying to produce more powerful substances, and then, with the results that we see now on the streets. People who use these sites tend to have a history of more overdoses and require more frequent injections. And in terms of the prevalence of hepatitis C and HIV, you can see it there in the systematic review. They said about 80% of people who use supervised injection sites have hepatitis C, and around 2 to 30% have HIV. And this matches what we see in Vancouver, for example, with the data of Wood and colleagues from 2005 reporting an 87.6% prevalence of hepatitis C and 17% of HIV. So that's about that's the kind of population, a client population that you work with as a nurse if you work in a site. And so that also speaks to, and I'll talk about practice later, but that speaks to the kind of care that people require. So they have complex health issues related to hepatitis C and HIV, but also mental health and trauma-related issues. And so being a nurse working with this client population is definitely the level of complexity like I don't think we see anywhere else. In terms of research, what we know about behaviors and harms, we know that at the level of behaviors, people tend to we see a decrease in syringe sharing and reuse. We also see a decrease in public space injection and more safer injection practices with increased use of sterile materials, which is exactly what we want to see as an outcome of supervised injection services. We also, this is not necessarily often an outcome that we think about, but as a result of coming to a supervised injection site, people tend to use more condoms, which is also another harm reduction approach that meets our objective. In terms of harms that we can decrease, we usually see more rapid care for skin and soft tissue infections, which is really important because often this is exactly the type of patient population that will evolve to a point of being so sick that they require really prolonged hospitalization, which is often something that's not realistic for them if they still continue to use. So it creates like very complex situations, so we can act quickly and prevent further health issues. It decreases overdose-related death, and there's never been a death recorded in a supervised injection site anywhere in the world. It provides a safer space away from the dangers of the drug scene on the street, especially for women who get to use in this space without having to interact or be exposed to threats or violence or abuse, power dynamics, and then they can just use in that space. It decreases bloodborne infections. That's one tricky one to find in the literature in terms of numbers. Authors tend to report very different numbers, and I've provided 2 examples there that you can see. But we know that they work at that level. It's just been hard historically to have a good piece of research that actually reports, a number that is consistent. Like it's been kind of a wide range of reported cases averted every year in the literature. In terms of treatment, with supervised injection sites, we tend to see an increase in referrals and treatment initiation. And post-insight in 2007, in an article, it was reported that was an increase in 30% in detox service post-insight. And I think often people don't think about it that way because they think that supervised injection sites promote drug use and that it's going to encourage people to use more. And actually, it's quite the opposite. It's often by creating a relationship with people that haven't had a relationship with healthcare providers in a very long time, and actually showing them that providers care and they're there for them, and if ever they have questions and they're ready, or if ever they want a referral, that this is something that can be done. It can be done the same day. There's not going to be barriers or wait times, and it can be facilitated by the nurse. And just having that, proximity and trust building, and the ability to refer and connect with other services actually increases the likelihood of people going into detox and accessing treatment much more than if they are on the streets injecting them by themselves. So in terms of public spaces, we see a decrease in public injecting, which is a big issue, both in terms of harm reduction and also in terms of the community, and decrease in unsafe syringe and needle disposal, and decrease in complaints as well. And at the level of crime, again, like often people will say, oh, well, if we open a supervised injection site, it brings crime, like it just will become a focal point, and everyone will, around this site, crime will increase and drug trafficking. And actually there's no evidence of that scientifically. And in Australia, they did a 10-year review, since they were running these sites for quite a bit of time, and they did a 10-year review and have not seen any increase in drug-related offenses in that 10-year period. In terms of costs, I'm not big on money. I don't like to talk about money when we talk about healthcare, but I think you kind of have to sometimes, especially with the kind of barriers that we face in terms of decision makers and politicians. Often this is you have to speak their language, and they often respond to the money. And I think it's important to note that there's enough evidence right now to show that it's not only cost effective, but it's cost saving. And the average benefit-cost ratio is for every dollar that you invest, you get a little bit more than $5 in return. So if you think about harm reduction and preventing harms and preventing risks to your health, it's better to invest at that level where you can actually prevent someone from contracting HIV or Hep C, or for developing a very, hard wound to treat, or endocarditis or pulmonary embolism, than to actually tackle these health issues that are really expensive and we have to treat anyway. So it's really better to work at the level of prevention, which is exactly what supervised consumption sites do. So at the level of policy, it's important to connect the dots in terms of connecting the research to the policy to the practice. Anybody who's interested in supervised consumption site needs to understand the policy side of things. Otherwise, it's just there's a big chunk missing of the story, and that's a really important one, because this is basically what the context in terms of the policy is what determines if we can open a supervised consumption site or not. So whether or not, like as a nurse, you want to do this kind of care, whether you can do it or not is basically depending on the laws that we have in place and the policies we have in place. So it's important to understand that context as well, especially that it's been so influential in the past few years. So without going too much into the history, I think it's important to understand that in 87 was the first national drug strategy was first introduced, followed by a second version in 92, and this version in 92 included a harm reduction pillar. So starting in 92, Canada was known as a champion in harm reduction. It was part of our national drug strategy, and it was also, when it's part of our national drug strategy, it also means that we want to dedicate resources and funding to harm reduction. And this is why we've, developed these needle exchange programs, and it's just like we were definitely ahead of the curve in terms of developing harm reduction programming. And in 96, the Controlled Drugs and Substances Act was created, and as part of that was a section called Section 56 that allowed for a federal minister of health to give an exemption for medical and scientific purposes or in the public interest. So that would mean, and that's exactly the scenario of a supervised injection site, that a federal minister of health could give, for example, Insight, an exemption under Section 56 to operate, as a supervised injection site, and for everyone to be in that site to be protected from criminal prosecution, including the nurses. So if you want to understand the policy side of things, you need to understand that Section 56, because still to this day in 2017, we still operate within that framework of having to request an exemption under Section 56 and then being granted one and functioning within that framework. So it's still very much part of the picture right now. And this is why I was talking about active sites and the ones who are going to open and the ones that are waiting for an exemption. It's our framework still to this day. And in the 90s came the overdose crisis in Vancouver, which is nothing compared to what we're facing today. But that gave rise to the Vancouver approach. They developed a framework with one of the pillars was harm reduction, and that was very influential and at the national level. And then at the national level, we kept that pillar as part of, the national drug strategy into the early 2000s. And in 2003, Insight was granted an exemption under Section 56 for 3 years to operate, and then to also prove that it was working, which is why we have so much science on this. But in 2006, a conservative government was elected. And it is important, and this is when you realize as a nurse that politics is as important as, other aspects of nursing practice, because it really determines the context, the broader context within which you're going to practice and the reality on the ground. So when that conservative government was elected, that same year, the health minister at the time, Tony Clement, granted Insight a 15-month extension for the exemption. And then the next year, that government introduced what they call the National Anti-Drug Strategy, sending a very clear signal that they would focus on prohibition and, the tough on crime, drug war kind of approach that we know does not really work. And Canada became one of the biggest opponents of harm reduction on the international scene. And so you can imagine how that created a very difficult context for the expansion of supervised consumption sites in Canada. So when it came time to Insight, it came at the end of that extension that the minister had provided in 2006. Insight went to the BC Supreme Court to ask to stay open, and then the BC Supreme Court ruled in favor at the same time as I was granted a 6-month extension, which of course is not enough to really plan activities in the longer term. It was just a matter of keeping it open just a little bit longer. And the BC Supreme Court ruled in favor of Insight because it recognized that closing it would violate the Charter of Rights and Freedom, which includes the right to life, liberty, and security. It would also go against this idea that provinces are responsible for health matters, and this is a health matter and not a federal matter. And so the government at the federal level was not very happy with that, decided to take this case to the Supreme Court of Canada, and all judges ruled in favor unanimously of Insight, recognizing the exact same thing as the BC Supreme Court, that closing Insight would contravene the Charter, and then decided to establish 5 criteria that would need to be met in order to determine if an exemption could be granted. And also asked the federal government to develop a proper legal framework for determining who gets an exemption and under which circumstances, and what kind of homework do they have to do to get an exemption, and how does this whole thing works, basically. And so the federal government at the time, still conservative, still not in favor of supervised injection site, developed a bill initially called C-65 and became C-2. And that bill, basically, think about the most difficult circumstances and criteria that you could come up with to prevent further supervised injection site from opening, and then that's what they basically put into that bill. And that bill passed, and then the Liberals were elected later that year. And in December of 2016, a new national strategy was introduced, and harm reduction was reintroduced into that national strategy. We're still functioning under Bill C-2 right now, which means that we're still functioning with that extensive list of 26 criteria that people have to meet in order to get an exemption. We're still functioning within that legal framework. A new bill was introduced. It's called C-37, and it uses the 5 criteria initially outlined by the Supreme Court of Canada. There's been some criticism of that bill. It's not perfect. I'm not going to go into the details of that, but I think it's really important as a nurse to understand that it comes down to harm reduction and providing health care to people, but you have to operate within this legal framework that makes it really, really hard to be granted an exemption. And even under C-37, it's still going to be hard. It's still going to take time. It's still going to require a lot of resources and time for an application to be complete and then submitted, and then you wait for an answer, and then you may have to revise it and resubmit, and it's still like a very bureaucratic, heavy process, and it doesn't really allow us to move quickly in the context of, for example, right now, the current overdose crisis. So it's not necessarily the ideal scenario. In terms of practice, this is my favorite part. It's been recognized quite early on that what nurses do in a supervised consumption site or service is part of a normal scope of practice. It's nothing more than what nurses do in other settings. It doesn't require anything, no special skills or special orders or advanced directives or anything. It falls directly within the scope of practice of registered nurses. And CNA, RNAO, and RNBC, because of that, made that very clear to the judges at the Supreme Court of Canada when they intervened in this inside case, and also clear to policymakers when they testified for Bill C-2 and Bill C-37, in order for them to understand that what nurses do in these sites and services is normal practice. It's nothing more than that. There's something special about it, but it falls within the scope of practice, so nurses should be allowed to do that. And the Ordre des infirmières et infirmiers du Québec in Quebec, OIQ, the regulatory body developed a position statement in 2009 on supervised injection site in favor of it. The one thing I would say about nurses who work in supervised injection services is that they definitely have a very unique practice, and it's a very uncharted territory to this day. It's a unique blend of acute care, primary care, community health, mental health, trauma-informed care, harm reduction, HIV care, hepatitis C, etc. But I would say these are the main ones. It's also, on top of the street knowledge that you need to have in order to be functioning in that and be seen as competent and credible, to know the language and the drugs and the drug effects and the drug preparation and the materials that are used and the preferences of the users and the prices and the trends and what's happening on the streets. It's extremely important. It also requires experience, including experience with the client population. It requires a lot of trust building, a lot of communication skills and personality, and I just want to emphasize that in the empirical literature, it's also clear that the nurse can be a barrier to these sites and it can be a facilitator. So if you have the right person with the right skills and the right knowledge, it can work and work really, really well. And I think that's what we've seen at Insight, because, having worked with the staff is just, fantastic. But if you have the wrong person with not enough experience and not the right knowledge, it can actually be one of the biggest barriers, and people will stop using these sites. So the people make the biggest difference, because otherwise people don't necessarily want to come and feel judged or feel like they're being policed or talked to in a way that they don't appreciate, or being asked questions when it's not the right time, or that you don't really get what they're trying to say, or you don't know the language. Like, that's enough to actually turn them off and just break that relationship and just prevent them from using the sites. So it's extremely important to have just the right people. And the right people also means that they have a broader understanding of the legal, political, and social issues, because you don't practice in a vacuum. Like, you practice in a setting with people who are criminalized. You have to understand what that means, like, issues with the police, like, the politicians, like what's happening at the bigger level is really important for any nurse who wants to work in these services or these sites. Insight developed its own nursing framework, which I'm a big fan of. It clearly shows that the client is at the center of the care. After that, you see that the next circle is the relationship building, and that's really, really important, because you can't get to the nursing care if that relationship is not built. And sometimes it's just a matter of taking enough time to build that relationship before you can even start thinking about care. And so before you, for example, offer an HIV test, like, that relationship needs to be built, and that trust needs to be there. So there's a lot of relationship building before anything can happen. So that just gives you an idea of what it looks like. So what nurses do, I've tried to capture this in a list over 2 slides, but I'm forgetting, I'm sure, many components of what they do, but it's just to give you an idea. So nurses are actually really good at preventing overdoses. And what I mean by that is actively preventing, for example, by identifying a client that you know tends to overdose more than others, or someone who's recently released from prison. And I used an example earlier when I did this in French of the day that I worked with the nurses at Inside in November. There was one client who was pretty young, like early 20s, who was just recently released from prison, and the nurse I was working with said, "Oh, I have to go talk to him." And she looked really concerned, and I said, "Okay, well, after, can you give me a bit of, what was going through your mind?" And she said, "Well, I saw what he was wearing, and these are the clothes that are given to people when they leave prison. So I automatically identified him as someone who would, be at higher risk of overdosing. I also know him quite well, and he tends to use, too much." And so she approached him in a very, great way, which, is not something you can learn in a textbook, and it's not something you can learn in a webinar. But she just did it in a way where there's automatically that relationship and, ability to assess him and know what's happening, what are you taking, and just getting a sense of what's happening with this guy, and just also taking more proactive steps to make sure he doesn't overdose. There's a lot of overdose management. Initially, Insight used to see one overdose every 3 months. And at the peak in November, they had 28 in one day. And when I was there, we had 15, including 5 at the change of shift within a 30-minute period. So that gives you a sense of how much the context can change. It used to be an exceptional event. Now it's a daily, hourly, event. So in terms of overdose management, includes airway management and resuscitation, naloxone administration, and also monitoring on site. There's a lot of people who overdose who will never go to the ER, and that's something that I feel we don't talk about a lot. In one study in 2008, it was reported that out of the 911 calls that were made for overdoses at Insight, about half required a 911 call. That's what I mean. So that's also what I've seen there. There's a lot of people who, if you act too quickly, if you call 911 too quickly, if you send them to the ER too quickly, they will never come back. So it becomes a matter of your clinical judgment, that relationship building, understanding the effects of the drug, because a lot of people, for example, that will inject heroin/fentanyl will have the nod that we call. So they basically just seem like they're going out, like they're basically just about to pass out, where it's just part of the drug experience. So if you kind of panic and think, "Oh my God, this person is overdosing and I have to call 911," that's it. You've just ruined their drug experience. So they will most likely not want to come back. So you have to really gauge what's happening with the person, your clinical judgment, your understanding of the client population and their drugs that they're using and the effects of these drugs, and when to call and when not to call, because it's as important of not calling than calling, depending on the situation. And so there's a lot to consider. I don't think I could do that every day, to be honest, and that's part of, I think, why nurses get exhausted working in this context. Safer injection education is a big part of what nurses do. Management of injection-related infections also. Wound care is huge. In that literature review from OHTM, they said that about 60% of the care that was being provided was wound care and foot care as well. There's testing, pregnancy, HIV, Hep C, complex physical and mental health assessments, crisis intervention from people coming in just having been sexually assaulted, physically assaulted, someone walking in after being stabbed. The range is very wide, providing counseling and psychosocial support, assistance with transportation to other services, and referrals is a big piece of what nurses do. So referrals to the appropriate services, counseling, clinics, the hospital, a detox bed, housing, treatment, and knowing who to connect with and when it's appropriate to offer it and when it's not appropriate to offer it. And in terms of where to go next, I would say research is not really an area where I'm concerned or I feel we need to push for more. There's already a lot of people doing research on this. I don't think we're necessarily missing something, and it's just going to continue to grow in Canada and not be as Vancouver focused. And as other people implement these services across the country, we'll see more research coming, so I'm not really concerned about that. I would say at the policy level, where the conversation is going right now is that safer injection can be achieved if we don't address the what you inject part. So we've addressed so far in Canada, I think, the how you inject, so the education piece and the supplies and knowing, which sites on your body to avoid and, what's risky practice and, not to share a syringe. I think we've reached that level of in terms of programming and funding, and I think that's there. The where you inject is supervised consumption services. It's often where, it meets that need of having a place where you're safe from being arrested and also safer place in terms of the environment being clean and having access to supplies and what you need in terms of healthcare. So I think that's one thing. But then you have to look at what you inject. So as long as you inject a substance that is of unknown source and you don't know what you're injecting, it's really hard to say that the injection is safer. So I think we're at a stage now where increasingly people are pushing for prescription heroin, for people to be able to prescribe hydromorphone to people who don't really do well on methadone or Suboxone, for example, who for them that would be the best option. So looking at what people inject is really important, or what they smoke, but it's mostly around injection. So decriminalization is a big part of the conversation. The only reason why we have to go through Section 56 and go through all this process that I've described before at the policy level is because drug use is criminalized in Canada. So if it was to be decriminalized, then it would no longer be a criminal activity to use a drug, no longer be a criminal activity for a nurse to be providing care to a patient who's actively using drugs, like within a healthcare facility, and then everyone could be implementing these services without even requiring an exemption. So that's a big barrier that we have to face because of the way we've organized the system around drug use. And funding is a big challenge. So even if you are granted an exemption, you have to secure funding at the provincial level. And healthcare is a provincial matter, so funding needs to be at the level of the province. So that's another battle that people have to fight in terms of getting these services implemented. For nursing practice, there's going to be best practice guidelines developed by RNAO. It's in the process right now, and it should be out in 2018. I think there's definitely a lot of conversations to have around scope of practice and nursing roles within supervised consumption services. It's still very new, and there's really nothing formal around the knowledge and knowledge transfer that's been developed on this. It's all in the nurses' heads as they develop all this specialized knowledge and expertise, but it's not being transferred so easily to other providers who came on the team, or other people who would like to learn about nursing practice in that context. So we need to, I think, formalize the knowledge and knowledge transfer and look at different models and team composition, and also invest in mentorship and retention of nurses, because you can imagine that there's a big turnaround of staff, and mentorship is really key, especially if you think of the model, for example, like the Montreal model, where a nurse is going to be practicing on our own with a team of workers from the community-based organization. But we have to look at how we support nurses who are working in a very uncharted territory with knowledge that they're developing. That's not something that they learn in nursing school. There's not really a book that's going to show you, what you need to learn. It's all coming from different places, and the mentorship and retention are two big pieces that I would push for. Where to go next in terms of improving supervised consumption sites, and this will be my concluding slide. I would say looking at wait times. In 2014, when OHCN did lit review, they reported that 15 to 30 minutes waiting time for insight before people could come into the room and inject, and that's not really the case right now. I'd say sometimes it goes up to 60 minutes, and people either leave or they decide to inject in the waiting room, or they end up overdosing in the waiting room. Wait time is big, and that's also why the pop-up supervised overdose prevention sites that I mentioned before are popular, because they're meeting the need of people who need to inject now. They don't have 45 minutes to wait. That's not how it works. It's not open 24 hours. It's only recently in the fall that Insight started doing open 24 hours around check day, because there's such a spike in overdoses. but it's not open 24 hours a day. Splitting or sharing of drugs is not permitted. There's no supervised inhalation possible, and there's nothing in the works right now that I know of in terms of the applications that were submitted. So that's also a population we're not reaching. And last week was reported one day at its peak, the overdose prevention site where I volunteered in the fall saw in one day 465 people, and out of the overdoses that they intervened on, 2 were from smoking. So it's just like also keeping in mind that overdosing is not just from injecting, it can be from smoking as well. Assisted injection is not possible at the moment, so that means that anybody who requires help injecting is not able to get that help in a supervised consumption site in Canada. And in the scientific level, we know that requiring help with injecting is negatively associated with use. So the more people require help, the less likely they are to use the site because they can't find that help within the site. So they will ask for that help elsewhere. Often hit doctors, like people who will inject you in exchange for money or for drugs with not the best technique and not the most safer way. There's a high prevalence of assisted injection, often with the most vulnerable people. If you look at youth, a very recent study looked at youth between 14 and 26 who were injecting drugs, and almost 1 out of 2, 49% of youth were required assisted injection. Women are more likely to also require assisted injection, people with disabilities, and I saw a lot of people in wheelchairs that had decreased motor skills that would for sure require help injecting. There used to be Vendu, which is a drug user group in Vancouver, for 4 years, had a pilot initiative. It was an injection support team where peers would go out into the streets, and if people required help with injecting, they would inject them in more safer conditions. And in Barcelona, nurses are allowed to do assisted injection. Not in Canada at the moment. There's a great documentary that is part of the web links that you have at the bottom of the screen, developed by the Legal Network back in 2007. So they were way ahead of the discussion, looking at why it's so hard to put that into place, but it's not impossible, but it would require some legal changes. And we know that people who require assistance are at increased risk of harm. So if we're serious about harm reduction, at the moment there's not one, supervised injection site active and about to open or in the works who are actually addressing that assisted injection component or that inhalation component or, the splitting and sharing and the waiting time. So there's a lot that I think we need to bring into the conversation as we're thinking about more of these sites opening. Thank you.
Great. Thank you so much, Marilou, for your really comprehensive and passionate presentation. So to our audience, if you haven't already, please type any questions into the Q&A box that you see on the right of the slide, and we'll start the discussion portion of the webinar. We have a few minutes to answer some questions. So I just wanted to go ahead and ask, how can we adopt this model in an acute care hospital? Can we integrate supervised consumption services in that way, and what would be the responsibilities of a nurse?
Yeah, actually, there's some people right now who are working on looking at this option. So people at University of Toronto, Carol Strike being the lead researcher, looking at harm reduction in the context of hospitals. In Vancouver at St. Paul's Hospital, they are in the process of developing a policy to, kind of address these questions for what happens, because often the option is people need to use, like they're not going to become abstinent just because they're hospitalized, like that's unrealistic. And so they often leave against medical advice because we don't provide anything for them to do that in a safe way, and we're just, very kind of abstinent focused in the hospital. So they end up leaving, which is really not good, or they end up using in the bathroom or in the stairwells where they're, really, found like overdosing and difficult situations. So I think there's a way of doing that, and some really good people are looking at that option right now. The role of the nurse would be very similar to what nurses do in terms of providing the supplies that people need, answering questions if they have, being present in terms of if something bad happens, like if someone starts showing sign of an anaphylactic shock or an overdose, and just doing what you would be doing normally in the hospital if this happened. but it doesn't really go beyond that. But I think we need to do a lot of work around the policy level for sure, because that's not really being looked at all that much through the model that's being proposed of how you're being granted an exemption and then you open a service. Like that doesn't really work in the hospital context. But yeah, like it definitely requires a lot of work at the level of policy and the culture and how do you do that in the hospital. But the reality right now is often people end up leaving. So we have to do better.
Great, thank you. And we have a question too about, do you think this role fits well within the community health nursing model of practice from the Community Health Nurses of Canada? Marilou, I'm not sure if you can speak to that. If not, I can add.
Yeah, go ahead.
I was just going to say absolutely. I am a certified community health nurse from the Community Health Nurses of Canada, and the standards and competencies that they have, the role of a nurse within supervised consumption sites absolutely would fit within that those competencies and model of practice. I don't think there's any question about that. So there are some questions actually about the overdoses that you had mentioned from inhalation.
Yeah.
There's a question around, do you know what they were using? And then also some questions about using services. Would there be a need for snorting during supervised consumption sites, also allowing, snorting of substances too? So
yeah. I think that the idea of a supervised consumption site, like that, means that ideally if someone could go in and snort it and smoke it and inject it, and how they use the route that they use would be welcome in that space. The reality, to date, has been that it's mostly been focused on injecting because we felt that this is the most harmful route, and often, like people that presented overdosing, would, be people injecting. It's no longer the case right now because we know that the drugs have changed. But it used to be that it was easily kind of like, a group that would be easily targeted with, these services. But now it's just everyone, people snorting are also overdosing. So it just shows that the drugs have changed since 2003 a great deal. And that to go back to the question of what people were using, I think right now, it's just what people are saying that they bought or that they think that they're using is not what they're using really. So we don't really know. And testing these substances is a challenge. At Insight they had like a pilot project that didn't last all that long, but where they would test with a little dipstick like we use for urine dipstick. Basically, it's the same way that it works for fentanyl, and they would dip the drugs just to see the presence of fentanyl, and just fentanyl is just in everything. So people would often come in and say, oh, I bought this, thinking they bought something else, and then that's not what showed up in the drugs. So I think it's just the reality of an unregulated market that just people don't know. They think they know. They think that they're buying something. So what that person smoked, we'll never know. And what they think they smoke is really probably not what it is, in fact. So it's just the reality right now of just, what you think you're buying. And that's true for cocaine and recreational use. It's true for MDMA for, university students who want to party. What you think you're buying is not what you're buying, and there's no way of knowing because we don't have testing here in Canada that is widely available. But if we were serious about harm reduction, drug testing would be easily available.
Thank you. So I think I see some people kind of dropping off because I know that people usually book about an hour for the webinar. So maybe I'll ask one more question if that's if that's okay. So this one's related to law enforcement. So related to safety from arrest. Marilou, do you know of any SIS policies and procedures or process documents about how they've effectively worked with police or legal services to keep the SIS as a safe environment?
Well, the exemption provides that. So when you get that exemption under Section 56, within the parameters of that service or site, the cops are not able to come in and arrest anybody. Like it prevents anybody within that site to be arrested in terms of drugs. Like let's say someone would come in and like punch a staff member in the face, like they can get arrested for that. But I mean, in terms of their drug use and nurses providing care in that context, which sometimes means that they're helping the patient cook their drugs or, you know, doing things like, you know, just talking to someone who's handling their illegal drug, like no one can get arrested within the parameters of that space. And that's why it's, you know, really a safer space to consume your drug. But once you're, you know, I think there's been a lot of work with the police department in Vancouver to prevent people from, for example, being arrested just before they get to inside or when they leave, or, you know, so that police are not just like parked before, you know, just in front of the door waiting for people to show up and arresting them. There's been a lot of work with the police department and a lot of support from them. Like they know. Cops who work in the downtown east side, they know the population and they know the issues and they understand what Inside does. So, but that requires a lot of work, a lot of community building, relationship building between different groups. But a lot of support came from the Vancouver Police Department, but there's still a lot of work that needs to be done. But around Inside, I think by now a lot of, you know, they understand what Inside is doing and it's working.
Great, thank you. I think there was an appearance before the Senate Standing Committee on Legal and Constitutional Affairs, which CNA was privileged to be able to attend, and there were some questions, not to CNA, but to some of the other individuals from City Councillor from Vancouver, and questions about things were presented as police officers being too afraid to go to Insight because it's so dangerous, but the respondent really actually highlighted that, as you said, Marilou, it's really more about the development of the relationships and the understanding of the roles that the site plays in reducing harms, and that the police, they don't go there not because they're afraid or they're afraid of the community, but because they want to support people's access. So I think it speaks to the relationships and how important that is. But, so thank you so much, everyone. We do have many more questions, but I know that we are out of time. And thank you again, Marilou, for your presentation on supervised consumption sites. And thank you to everyone who attended. We hope this session stimulated your thinking about nursing practice and how to advocate for and shift policy. Marilou's contact information is there, as is mine. If you have any questions or concerns, please feel free to contact either one of us. And if you haven't already, please consider registering for our next webinar, Creating Safe Spaces in Healthcare for People Who Use Drugs, which will be held on Tuesday, May 30th from 12 to 1 Eastern Time. And thank you again, everyone, for attending and participating. Goodbye.